Hi, welcome to Southern Nevada Bariatrics. I'm Dr. Mustafa Ahmed, and this is a seminar that I'd like to talk to you about regarding bariatric surgery / weight loss surgery. A lot of people struggle with weight, and they've tried multiple different ways to try to lose weight, including going to the gym, to exercise, dieting, seeing a nutritionist, trying medications, and none of them have seemed to work. So I'd like to propose to you the weight loss surgery as a way to permanently lose weight. And I'd like to go over the seminar. And I think that once you go through the seminar in full and I talk about it, you will realize the benefit of getting surgery done to try to lose weight, because surgery makes you lose the weight permanently, as opposed to all the other ways which don't prevent you from keeping the weight off permanently. It's only temporary. So let's get started. And again, welcome to Southern Nevada Bariatrics. And hopefully you'll get a lot out of this seminar. And hopefully I'll see you in the office after you watch this seminar. Thank you. So I'm again Dr. Mustafa Ahmed. I'm a Center of Excellence surgeon. I graduated from Ohio State University College of Medicine and Public Health. I trained in advanced minimally invasive surgery in addition to internal medicine and critical care, and I'm a fellow of the American College of Surgery. If you look at this map, it shows that from 1990 to 2010, people have gained weight. So let's figure out why that is the case. So what contributes to obesity? It is social behavior. We know that food is everywhere. There's lots of fast food options. In our culture, we eat to celebrate when we are sad, when we gather with friends and family. Also, there are certain diseases that cause you to gain weight. For example, if you have a low thyroid function, hypothyroidism, or you have diabetes, you can gain weight. Certain medications, especially psychiatric medications, can also make you gain weight, as well as insulin. And then certain injuries like back pain and knee pains or knee injuries can make you not be able to move around much, and as a result, you can gain weight. Genetics is another big one. If your parents were overweight, you may have a good chance of also inheriting that gene and gaining weight. Another one is energy imbalance. Too many calories in, not enough physical activity to burn your calories ingested. Finally, age. As we get older, our metabolism slows down. So we're here to prevent early death, to treat comorbidities, improve the quality of life, and you've tried everything else and nothing has worked. If you look at this woman, if you go all the way around and you can read it for yourself, everything in there is improved if you lose the weight. Quality of life, if you look at the bottom, is 95%. Everything, including migraine headaches, to high blood pressure, to diabetes, to coronary disease, everything improves. So why surgery? The National Institutes of Health, in a consensus statement in 1991, said non-surgical methods of weight loss are not effective over time. Medical weight loss, including Meridia, phentermine, Orlistat, and all the other weight loss medications, can help you lose an average weight of 10 to 30 pounds. However, there's a rapid weight gain after cessation of medications, and side effects are usually not tolerable over a long period of time, as well as the fact that it costs a lot of money to buy these medications, and it's not sustainable over a longer period of time. So how do we know whether you're overweight or not? We use the body mass index. It's the weight in kilograms divided by the height in meters squared. This is an imperfect measurement, but it works for most people. This is an old school method of figuring out your BMI. On the y-axis, or the long axis, up and down, it is your height, and across is your weight, and where those two come together is your BMI. Nowadays, we don't use that. All you have to do is go to your phone and go to Google and just put in BMI calculator. You put in your height, your weight, and it tells you what your BMI is. So criteria for surgery. The National Institutes of Health, as I said, in 1991 came up with this list of criteria. If your BMI is greater than 40, you don't need anything at all. No comorbidities, no medical problems. You can be completely healthy and you're eligible for surgery. If your BMI is between 35 to 40, you have to have one comorbidity at least. And this is just a sampling, but there's a lot more, and each insurance is different. Coronary disease, diabetes type 2, high blood pressure, sleep apnea, something called pseudotumor cerebri, which is just essentially high blood pressure of the brain, and usually occurs in women who are in their 40s. History of failed sustained weight loss on supervised weight reduction surgery. You cannot have any substance abuse, you cannot have any psychosis, and definitely no uncontrolled depression. So what's the expectation for weight loss surgery? Surgery is only a tool. Long-term weight loss up to 65 to 75% of your excess weight. There's remission or significant improvement in comorbidities, including diabetes, high blood pressure, sleep apnea, heartburn or gastroesophageal reflux disease, also known as GERD, and osteoarthritis. There's reduced medications and there's better quality of life. Expectations of the bariatric patients. You attend educational classes, you follow the program guidelines we set for you, you do lifestyle changes and modifications, we do a preoperative weight loss, and we'll talk about that in the office, and you also have a lifelong follow-up with me in the office. So what are the successful eating strategies? It's always important to eat protein foods first, 3 mini meals per day, chew each bite at least 30 times. That prevents you from eating too fast. Enjoy proteins, vegetables, and fruit. Avoid sodas and juices, and exercise daily to get your body moving. So preparing for surgery. 2 weeks of shakes before and after surgery, followed by regular food start 2 weeks after surgery. There's lifelong multivitamin and calcium, and lifelong good eating habits. This shows you what your anatomy looks like right now before surgery, and you can see that for yourself. It's self-explanatory. So the different surgical procedures are the adjustable gastric band. We don't really do that anymore. Now we actually take them out. It's a restrictive procedure that reduces how much the stomach can hold. It's the least invasive procedure. It's a low malnutrition risk. It's a foreign body, and it takes 2 to 3 years for excess weight. And it's removable. You have to realize that the food only goes into that part of the stomach that's above the band. Let's watch a video.
During a minimally invasive procedure, an adjustable band is placed around the upper part of the stomach, creating a small pouch. The band is connected by thin tubing to an access port below the skin. Through this port, your surgeon adjusts the lap band by inflating or deflating the inner balloon with saline. As the band inflates, the stomach outlet becomes smaller. This helps reduce the amount of food you eat and slows the emptying into the lower stomach, helping you feel full sooner, stay full longer, and reduce hunger urges. This procedure does not require any rerouting or stapling of the anatomy.
Next one is the vertical sleeve gastrectomy. This one is like the band, as there is restriction. The stomach's transected into a tube. There's low malnutrition risk. There's no foreign body. There's very few food intolerances, and few patients dump. And I'll talk about what dump means later. Let's watch a video of the sleeve gastrectomy.
The sleeve gastrectomy is a restrictive procedure which limits the amount of food you can eat by reducing the size of your stomach. To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form, so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
Next one is the gastric bypass. This is the Cadillac procedure of bariatric surgery. It's both a restrictive and a malabsorptive procedure. It involves cutting and stapling of the stomach and intestines. There's no foreign body. It can be reversed. And there's something called the dumping syndrome, which essentially means that in a normal stomach, there's a valve called the pylorus. And once the food is digested in the stomach, the valve opens slowly and lets a little bit of the digested food into the intestine to be absorbed. Well, when there's a gastric bypass, there is no valve. So all the food that's in the stomach goes immediately into the intestine, and the intestine doesn't like it because it's too concentrated. And as a result, fluid comes into the intestine and the intestine swells, causing pain, and then in a few minutes you'll also be getting severe diarrhea. That's why it's called the dumping syndrome. It occurs if you eat lots of sweets like cakes and ice cream. So patients who have had gastric bypass are warned not to eat a lot of ice cream or cakes or anything super sweet. Let's watch a video now of the gastric bypass.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
All right, so let's compare the three: band, sleeve, and gastric bypass. For excess weight loss the first year, for the bands it's 40 to 50%. For the sleeve it's 55 to 65%, and for the gastric bypass it's 70 to 75%. So let's put this in real terms. So supposing you weigh 300 pounds and you're supposed to weigh 200 pounds. Well, that means you have 100 pounds of excess weight that you need to get rid of. Well, with the band, you'll get rid of 40 to 50 pounds. With the sleeve, you'll get rid of 55 to 65 pounds. And with the gastric bypass, you'll get rid of 70 to 75 pounds. Now, if you want to lose the rest of it, you'll have to do lots of exercising and watch what you eat to get to lose all 100 pounds. Reversibility is very difficult for the gastric bypass, but it can be done. The sleeve is not reversible as we remove part of the stomach, and the band can be reversible because you can remove the band. Food intolerances, as I said, is worst for the gastric bypass because of the dumping syndrome, and you cannot eat lots of sweets. Dumping syndrome, again, is most common with the gastric bypass. It rarely occurs with the sleeve, and that's extremely rare. There's vitamin deficiency, most common with the gastric bypass because you bypass part of the intestine, which absorbs calcium, vitamin D, vitamin B12, and iron. So every few months, I have to draw blood to make sure that you have enough of those elements. Otherwise, you'll have issues with anemia and so on. Weight loss with high BMI is most significant with the gastric bypass, but also with the sleeve. And you need lifelong multivitamins for all. So what are the basic requirements? Once you come to see me in the office, we'll do a psychiatric evaluation as well as a nutrition evaluation, and I'll send you to a nutritionist. Typically, for the nutritionist, it's 4 to 6 times before surgery, but it can be a little less depending on your insurance. Psychiatric evaluation is only once. We'll also send you for a sleep study if you're required to do so, either by your insurance or you have symptoms of sleep apnea. If you smoke, I'll send you for a pulmonary evaluation, and everybody gets a cardiology evaluation to be ready for surgery. We'll also get a letter from your primary care physician, a referral letter, as a lot of insurance companies require a referral letter. We'll also be doing your documented weight loss preoperatively. Some insurances, very few at this time, require 2 to 5 years of previous documented weight loss. So how do I help? Guidance for proper nutrition, guidance with proper exercise and referral to a gym, safe surgery, and regular follow-ups. Myths about bariatric surgery. Bariatric surgery is dangerous. Patients eventually regain their weight. Bariatric surgery is expensive. There is no other disease that can negatively impact the entire body like obesity. The mortality risk rate for an obese person is 1 to 2% per year compared to the actual risk of surgery, which averages from 0.05 to 0.5%. So what this means is that you have much higher risk of dying from being overweight than from surgery. If we compare different bariatric procedures, the average 30-day mortality is 0.28%. Now let's compare that to other surgeries. The craniotomy is 10.7%, esophagectomy is 9.1%, pancreatectomy is 8.3%, pediatric heart surgery is 5.4%, aortic aneurysm repair is 3.9%, open heart surgery, or known as CABG, is 3.5%, and bariatric surgery is 0.28%. Even gallbladder surgery, which is the most common procedure in the United States, is 0.35%, and it's a higher risk than the bariatric surgery. So what I'm trying to tell you is this is a very safe procedure. If you look at this graph, it shows that in the first year, people lose significant amount of weight for the band, for the sleeve gastrectomy, as well as for the gastric bypass. However, after 1 year, you can see all those graphs, the slope goes up, meaning that you regain a little bit of weight. So after a 10-year period, people average between 5 to 10% regain in weight. So if you lost 100 pounds in a year, you're likely to regain 5 to 10 pounds over the next 10 years. And that's just the way it is. Most people find it extremely difficult to exactly keep the weight off all the time. This final graph shows you that over time, you save money by having bariatric surgery. Initially, it may cost more to have the surgery, all the expenses, but over time you save things on like co-pays, on medications that you don't need anymore because you're not a diabetic anymore, you don't have high blood pressure anymore, you don't have a lot of different medical issues, and therefore you don't have to worry about those expenses. You don't have to worry about being admitted to the hospital because of you have congestive heart failure, so on. So in the long run, you're better off having bariatric surgery. Next steps to getting started. So when you come in, we do insurance verification. There's a form you fill out, and you sign it, and we'll do the work for you. Then we acquire and submit referral letter from your primary care physician. We schedule your initial established care visit. Then, once you come in, we do your psychiatric and nutrition evaluation, and then we order blood work as well. And then we initiate the medically supervised weight management by having you come to the office on a monthly basis, and depending on your insurance, it can be between 3 and 6 months. We know there are other bariatric programs to choose from here in Las Vegas. So I thank you very much for attending the Southern Nevada Bariatrics Seminar online, and I hope to see you soon. Thank you.